Good afternoon, everyone. Welcome to our cardio webinar, Fatty Liver Disease, a Silent Epidemic. I'm Dr. Michael Constant, the Principal Investigator of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio, and I'm joined by Dr. Sherry Boland, Co-Principal Investigator of Cardio. Founded in 2017, Cardio's mission is to improve cardiovascular and diabetes health outcomes and eliminate disparities in Ohio's Medicaid population. Cardio brings together Ohio's 7 medical schools to identify, produce, and disseminate evidence-based cardiovascular and diabetes best practices to primary care teams. To learn more about the collaborative and to access our online repository of best practices, please visit our website, cardio.org. I would like to acknowledge and thank our sponsor, the Ohio Department of Medicaid, and our administrative partner, the Ohio Colleges of Medicine Government Resource Center. I would also like to recognize the partnership of Ohio's 7 medical schools who contribute to make Cardio Collaborative a success. If Dr. Boland is on, she'll proceed with our logistics. Otherwise, I'll take care of that.
Thanks, Mike. Can you hear me?
Yes, we can, Sherry. Thank you.
Thank you. Yeah, just some brief logistics. Your Zoom display name should contain your first and last name for attendance purposes. If you're joining as a group, please use the chat feature to record the names and emails of all the attendees that are with you. And we want you to submit questions for discussion, so please use the Q&A feature to submit questions at any point during the webinar, and we'll answer those during the Q&A portion of the webinar. And we will have a post-webinar evaluation survey that will be shared at the end of today's webinar and sent by email so that we can decide what you liked, so we can keep doing that for next time, and if there's any improvements that may need to be made as well. You can claim CME, so just this is our disclosures. There's nothing relevant to the presented work today. Again, if you want to claim CME, you do actually need to register. So the QR code here, if you haven't registered, use that and you can register. And if you express interest when you register in claiming CME, we'll send you a separate survey from myevaluations.com to complete that. If you have any questions or concerns and you don't get anything next week around that, just contact Kathy Sullivan. And with that, we'll go ahead and turn it over. I'm going to introduce Dr. Zack, who will introduce the speaker. But Amy Zack is a family medicine physician and vice chair of education at Cleveland Clinic and faculty at Case Western Reserve University School of Medicine. She's the lead for education dissemination for Cardio, and I'll turn it over to you. Thank you so much.
Thanks, Sherry. It's my privilege today to introduce our speaker, Dr. Lanla Conteh. Dr. Conteh is a transplant hepatologist, section chief of hepatology, the director of endoscopy, and an associate clinical professor of internal medicine at The Ohio State University. She attended medical school at Case Western Reserve University and did residency in internal medicine and pediatrics at University Hospitals of Cleveland. Dr. Conteh completed her fellowship in gastroenterology and transplant hepatology at Vanderbilt University, where she also obtained a master's in public health. Her research interests are in hepatocellular carcinoma, as well as the disparities in patients with liver diseases. Dr. Conteh has served nationally with the National Medical Association, as well as on the Minority Affairs and Cultural Diversity Committee of the American College of Gastroenterology. Additionally, she's on the writing group for Practice Guidelines Committee for the American Association for the Study of Liver Diseases, and working on updating both national and international guidelines in liver transplantation. In addition to her clinical, research, and administrative roles, Dr. Conteh has been recognized as an excellent educator and has received many awards from The Ohio State University. Despite many professional accolades, amongst her most important roles, however, are as a mom to 3 amazing children and sharing her life with her incredible husband. Please join me in welcoming Dr. Lanla Conteh.
Dr. Zack, thank you for that wonderful introduction. And thank you to the sponsors. Thank you, Dr. Boland. Thank you, Dr. Constant, and to all the organizers of Cardio. I look forward to spending the next hour with you. The objectives of my talk today are to screen and identify patients with MASLD and MASH, and we'll define those in a minute, to manage the contributing risk factors to MASLD in patient care, describe current disparities in risk assessment and management, and really to counsel stakeholders on the current risks, the treatment options, and the prognosis that we have for this epidemic. I really want to start off by highlighting that over the last year, there's been a significant nomenclature change in how we talk about fatty liver disease. Commonly, this is what we know it as, but you see a lot of letters in front of you. And in the next slide, I will explain what all those mean and the new terminologies that we are now referring to this disease as. So fatty liver disease, previously called non-alcoholic fatty liver disease, NAFLD, has undergone naming change in the last year. And a big part of this was really to remove the non-alcoholic portion and really recognize the underlying metabolic dysfunction of this disease. And also the term fatty, as I'm sure we can all appreciate, has really been perceived as stigmatizing to specific patients. So now what we know as fatty liver disease is called steatotic liver disease, SLD. What we previously labeled non-alcoholic fatty liver disease, NAFLD, is now called metabolic dysfunction-associated steatotic liver disease. And I'll tell you that we all appreciate that this is a mouthful and difficult for even many of us to be able to say, let alone for patients. But our hope is that over time, this will become part of our vocabulary moving forward. MASLD really recognizes hepatic steatosis and at least one of 5 cardiometabolic risk factors as the contributing factors to this disease. What were previously called NASH, non-alcoholic steatohepatitis, we now call MASH, metabolic dysfunction-associated steatohepatitis. I lay this groundwork so we know what this is now called going forward. Throughout the course of my talk today, you'll see me going back and forth within these terms a little bit, but I just wanted to establish what those new terminology really stand for. So nothing new except for the names and how we label them. There's a new terminology that I want to highlight for you, and this is called MASLD, metabolic dysfunction plus alcohol-associated liver disease. And as you can see there, this really quantifies the amount of alcohol that men and women use within a week to qualify under this diagnosis. And this was developed as a different, distinct category from MASLD and also from alcoholic liver disease alone, where the contributing factor is only alcohol consumption. But I'm sure that we can all appreciate that there are a subset of patients in whom metabolic dysfunction is predominant, but alcohol use is also predominant. And when we put those two things together, we know from multiple studies that these two entities really promote the development of cirrhosis and significant fibrosis down the road. There's a lot of names on here, but I do this to really highlight that the new terminology that we are using, MASLD, MASH, SLD, and MedALD, have been endorsed by multiple societies, both nationally and internationally as well. And again, our hope, though we recognize the mouthful of the new terminology, is that this becomes our common language going forward. So let's talk about steatotic liver disease and really define what it is, and then we'll delve into the specifics. So steatotic liver disease, again, what we previously knew as fatty liver disease, but really defining it better. And again, as I mentioned, the reason for this is really to highlight the significant metabolic dysfunction underlying these. So these are patients who have a BMI greater than 25 or greater than 23 if Asian, and this is how it's defined by our national organizations. Also have factors related to diabetes, specific serum glucose levels, have high blood pressure, elevated plasma triglycerides, or plasma HDL cholesterol levels that are also elevated. And again, you can see going through steatotic liver disease, for those patients who meet those factors of metabolic dysfunction I just went through, we will label them as MASLD. If there's significant alcohol use involved, we will label them MASLD. And if neither of those are factors, there's no MASLD or metabolic dysfunction, we strictly label them as alcoholic liver disease, ALD. At the bottom here, I highlight what the standard drinks are in the United States. And I really think it's important to make a note of this. I'm sure many times you have asked patients, how much do you drink? And you have maybe been told a glass of wine a day. It's real important to dig further and say, well, how much exactly is that? For all of us, a standard glass of wine is 5 ounces, or at least it's labeled as 5 ounces. But asking patients, really, how big is your glass? Is it 10 ounces? Is it 12 ounces? Is it 9 ounces? It's important to quantify that so we can appreciate how much alcohol use is playing in liver disease or steatotic liver disease in general. So why are we talking about this, and why is cardio focusing on this today? MASLD is the most widespread liver disease. The estimated prevalence is 38% in adults, and unfortunately, we're seeing an increase in prevalence in children, up to 13% in children and adolescents. It's an increasingly important contributor to global mortality and morbidity. And liver disease accounts for greater than 2 million deaths a year and 4% of all deaths in the world. And it shares common metabolic risk factors with obesity, with diabetes, and with cardiovascular disease, hence the focus on it for this specific talk with cardio. And I hope we can all appreciate by the end of this and throughout this talk that there are significant health, social, and economic consequences that impact all of us, our patients, our societies, and our communities, and globally as well. Unfortunately, as with many other diseases that we're all familiar with, patients are typically asymptomatic in early stages, and they typically don't present with symptoms until the disease has progressed significantly. We're highlighting this again today because recently, in 2020, there was a survey done of 102 developing countries, and no country had a written strategy of how to address MASLD or fatty liver disease, despite the significant burden that I just pointed out to you. So we have a lot of work to do in this area, particularly in the public health forum. The burden is expected to grow. And unfortunately, the incidence of liver decompensation, liver cancer, hepatocellular carcinoma, and death related to cirrhosis from this disease is expected to increase 2 to 3-fold by 2030. We are nowhere close to the peak incidence of this yet. And hopefully, by having conversations like this, we can help alter the trajectory of this disease going forward. MASLD-related cirrhosis is the leading indication for liver transplantation, particularly in women, and particularly in those over the age of 65. And it's on par with alcohol in this country as the leading cause of liver transplantation overall. And that is despite the fact that we have seen significant alcoholic liver disease in the COVID era and post-COVID. There are significant adverse outcomes related to disease stage. Again, we're highlighting this here today because the most common cause of death in patients with MASLD are related to cardiovascular events and also non-hepatic malignancy, and liver disease actually comes after those first two things. The amount of liver fibrosis, and fibrosis, it's a simple terminology to mean scarring of the liver, really leads to significant liver-related outcomes and deaths. You'll hear me talk about F0 fibrosis, F1, 2, 3, and 4. F0 means zero fibrosis, which is good. F1 and F2 are minimal fibrosis. When we start talking about F3 and F4 fibrosis, that signifies more advanced liver disease. F3 is bridging scarring, bridging fibrosis, and F4 is what we actually label as cirrhosis. There was a prospective study done of about 1,800 patients, and the all-cause mortality for patients who had minimal fibrosis, F0 to F2, was about 0.3 per 100 person years. As the fibrosis advanced, F3 fibrosis, we saw that all-cause mortality increase. And as patients developed cirrhosis, that all-cause mortality increased even more. And I highlight this to say that one of the focus points for us in healthcare, wherever you are in healthcare and whatever your role is to try to catch these patients at the earliest stages of their disease, because as you can see here, as they advanced with fibrosis, their mortality and morbidity increases significantly. And again, if we look at death from any cause, death from specific hepatic decompensation, death from liver cancer, or extrahepatic malignancy, as you advance F3 in blue and F4 in yellow, you can see that that mortality goes up compared to lower stages of fibrosis at F0, F1, or F2. So the risk factors for MASLD, unfortunately, are many of the risk factors that we see in other disease states: obesity, diabetes, dyslipidemia, and hypertension. There are others, but for the purposes of this talk, these are the ones that we will focus on. So when we talk about fatty liver disease, there are multiple mechanisms that are involved, from what we eat, as we're all aware, to how we move, our physical activity. And there are also genetic polymorphisms that have been brought into play. There's the gut microbiome that's involved as well. There's oxidative stress, inflammasome activation, multiple different steps, but all these things come together and act almost synergistically to promote fatty liver disease, steatotic liver disease, or MASLD. So let's talk about obesity. And unfortunately, I'm not sharing anything new with you here. Up to 30% of people with MASLD will have MASH. And MASH is steatohepatitis, which is active inflammation. That steatohepatitis undergoes fibrosis progression, so from F0 to F4, over time to cirrhosis. And the risk of developing MASLD increases threefold among patients who have a BMI greater than 25 or greater than 23 among Asian populations. There's a dose-dependent increase that is seen with every unit increase in waist circumference and BMI. So really significant. And again, I know many of us are dealing with this in primary care settings, in cardiac settings, and endocrinology offices, and something hopefully we are actively talking to our patients about. One of the things that I don't think we always recognize, though, is that body fat distribution is an important determinant in obesity and in MASLD. We know from multiple studies that patients who have android body fat distribution, so more central and truncal obesity, actually have a higher risk of insulin resistance, cardiovascular disease, liver disease, irrespective of what their BMI is. And patients who have gynoid fat distribution, so more located around the hips, actually that tends to be protective against many of these comorbid conditions and MASLD. And android, as you can see, again, that central truncal obesity, as opposed to gynoid, which is more protective, which is located around the hip. And obviously, our body composition is what our body composition is. But I bring this up to say that potentially we need to be really focusing counseling efforts on patients who may have that android distribution. Because again, regardless of their BMI, the way the fat is situated in many of these patients, unfortunately, increases their risk, again, for insulin resistance, cardiovascular disease, and MASLD. A big thing that I personally can relate to, it runs in my family, is type 2 diabetes. This is the most impactful risk factor for the development of MASLD, for fibrosis progression, and for liver cancer. And this really is due to central pathogenic role that insulin resistance plays in many disease states. We know that patients with type 2 diabetes have a higher prevalence of MASLD. And you can see the data there from 30 to 75%. So very, very significant. And we know that these patients are at higher risk for developing inflammation, steatohepatitis, and for going on to develop cirrhosis of the liver. And the probability of having significant fibrosis, significant scarring increases the longer the duration of type 2 diabetes in these patients. And something I really want to highlight is that this relationship is bidirectional. So having MASLD increases your risk of diabetes, but also having diabetes alone increases your risk of having MASLD. So it flows in both directions. So it really behooves us to try to control glucose levels in these patients as best as we can. And oftentimes the conversation comes up about, well, type 1 diabetes or this patient is impacted. And fortunately, patients with type 1 diabetes are not as impacted by MASLD, except if they have those other coexistent metabolic factors, such as obesity, hyperlipidemia, hypertension. I really want to spend a little bit of time on dyslipidemia, because I think sometimes because of the reputation that statins get, we don't always aggressively treat this disease in patients who have liver disease as we should. Patients with MASLD are twice as likely to have lipid abnormalities. One of the take-home messages is that statins are safe in patients with MASLD across the liver spectrum. In clinical practice, again, they're often underutilized, but they should be. One of the things that I want to highlight is aspirin use. So I compare statin use in liver disease with aspirin use in patients who have heart disease and may have GI bleeding. So oftentimes, one of the things we see when a patient has GI bleed but may have significant heart disease is a hesitancy to want to use aspirin because of their GI bleed. One of the things that we always tell our fellows and our residents is that we can stop a GI bleed, but we cannot stop a heart attack. And I hope to leave you with the same message today about statins. We can manage elevated liver tests if they're caused by a statin, but we cannot modify that ongoing cardiovascular risk if we don't implement a statin. So I hope at the end of this, you all feel more comfortable with the use of statins. So cardiovascular disease. This is an important cause of death in patients with MASLD. There's a strong association between MASLD and atherosclerotic heart disease, heart failure, and even arrhythmias. And the incidence of cardiovascular disease is unfortunately the same across all fibrosis stages. We do not see it necessarily be higher in patients who have more advanced fibrosis, such as F3 or F4. So again, really highlights that we need to optimize management of cardiovascular disease in all patients with MASLD, regardless of the significance of their liver disease. And I mentioned smoking cessation here because I think over time, at least in my practice, I feel like we have moved away a little bit from highlighting smoking cessation. And it's really important that we get back to those basics if we're going to modify cardiovascular disease and all the risk factors that are associated with it. So this is a busy slide, but this is really looking at liver-related mortality, specific liver-related decompensation. But what I want to highlight for you here is the cardiovascular events, so coronary artery disease. So across the spectrum, regardless of what your level of fibrosis is, in the setting of having NAFLD or MASLD, you will have significant coronary artery disease. So really important to identify early so we can start instituting modifying measures and modifying interventions to treat this disease. So in summary, regarding the MASLD comorbidities, patients with diabetes are at higher risk for MASH and advanced fibrosis. Patients with MASLD should be screened for type 2 diabetes. And again, remember, this is a bidirectional relationships. And again, one of the things that I want to leave you with is that statins are safe to use in patients with liver disease and should be used to modify the cardiovascular risk. Many patients will die from non-hepatic malignancies. So I also want to highlight the importance of screening, as I'm sure many of you do, age-appropriate screening. As a gastroenterologist and a transplant hepatologist, I can't give a talk without highlighting the importance of colon cancer screening. Alcohol use is an important contributor to MASLD progression and really should be quantified in all patients. Please don't shy away from asking your patients if they drink alcohol and really quantifying how much they drink. Because as we mentioned before, having these metabolic risk factors alone increases the risk of liver disease. And when you add alcohol on top of that, it almost becomes a synergistic relationship. Patients with MASLD should have alcohol intake assessed on a regular basis. And for those who have clinically significant fibrosis greater than F2, they should be advised to abstain from alcohol. And we know that alcohol use lowers the risk of fibrosis progression with hepatic and extrahepatic malignancies as well. Let's talk about screening. So when we talk about screening, we can't screen every single man, woman, and child for significant fibrosis. It would not be economical. So we want to target our screening at specific populations. And the goal of screening is to identify and manage those with clinically significant fibrosis, again, greater than F2, and also to ensure that we are continuing to monitor patients who are at high risk for developing clinically significant fibrosis. So patients with type 2 diabetes, patients with obesity, family history of cirrhosis, and again, those with significant alcohol use. And as we all know, the goal of any screening test is to identify patients who are asymptomatic before they develop symptoms. So these are the patients who should be screened in our offices, be that primary care, be that endocrinology, wherever it is that you may be working. So patients with type 2 diabetes, patients with medically complicated obesity, patients with NAFLD, MASLD, in the context of moderate alcohol use, and first-degree relatives of patients with cirrhosis due to fatty liver disease. So how do we screen? So our goal is to make this simple, and we have developed what we call a primary risk assessment to be used in our primary care settings. So this is done by what we call a fibrosis 4 index, also known as a FIB-4. And it's a simple blood test looking at the age, the platelets, the AST, and the ALT level. And hopefully there's a routine lab, so we're all checking in patients at least once a year. So FIB-4 is what we should be using for this primary risk assessment in our patients who are at risk for MASLD, particularly in our primary care settings. So this is a nice diagram that was developed by the ASLD, the American Association for the Study of Liver Diseases. So in non-GI practices, we recommend doing a primary risk assessment with a FIB-4. And you may be wondering, what is a significant value? So a value greater than 1.3 should prompt you to refer to a higher level of care. If the value is less than 1.3 and the patient has risk factors for MASLD, diabetes, etc., we recommend a FIB-4 be done every 1 to 2 years. However, if that FIB4 again is greater than 1.3, we recommend referring on to a higher level of cure, because those are the patients who may have clinically significant fibrosis or potentially even cirrhosis. So our screening summary, again, we want to do target screening, not general population-based screening, because unfortunately that is not effective. All patients with steatosis or clinically suspected MASLD should undergo primary risk assessment, again with the FIB4. And again, patients who are at risk, diabetes, prediabetes, those other metabolic risk factors should be screened with a FIB4 every 1 to 2 years, as should first degree relatives of patients with MASH cirrhosis. One of the things that I want to highlight as well is aminotransferase levels. In my practice, I see many patients who unfortunately have decompensated cirrhosis, who have liver cancer and multiple other things related to their liver disease. It's always jarring that many of those patients actually have normal ALT and AST levels. And I highlight that to say, if you check these levels and they're elevated in your practice, great, that's helpful. But if they're not elevated, but you still have concerns, please go dig in further, because normal levels don't always signify that disease is absent. This is what we all should be doing in the initial evaluation of patients with MASLD. These are things that I do in my clinic as well. I'm not going to go through each of these, but certainly these slides will be available for you to share and to have. So focus on the history, focus on the physical exam, and these are some baseline lab tests that we should be getting. I am a big proponent, obviously, as a hepatologist, that all patients should get a hepatic function panel once a year. I think many patients are getting a basic metabolic panel once a year. And it's the same purple tube. You can just add the liver test to that just to get a sense of how the liver is doing, just given the significance of this disease that we had talked about. I want to shift our focus a little bit to non-invasive testing. Over the years, we have seen significant progress in non-invasive testing, also known as NIT, that helps us assess disease stage for patients with various liver disease, but certainly for patients with MASLD. And the reason for this is that liver biopsy will recognize as the gold standard, but really a liver biopsy should not be used routinely for many reasons, due to cost, due to risk of bleeding, and also resource utilization. So non-invasive biomarkers have emerged as valuable tools. So I want to highlight again that the FIB4, as we look at non-invasive markers, FIB4 is the most validated. And again, this is calculated based on age, AST, ALT level, and platelet count. So for all of you living today from this talk at the end of it, please make the FIB4 a regular part of your practice in those patients that you are screening for fatty liver disease. I put this up just to share with you for awareness only that there are multiple other non-invasive tests that we have available in our arsenal. FibroScan, I'm sure many of you have heard about, certainly bread and butter ultrasound, ELF, FibroSpec2. So many things that you may read about, many things that your gastroenterologist and hepatologist may be doing as well. But for the majority of us, the focus really should be on FIB4. So this is looking at the histology of DAFLD. So I've talked a lot about fibrosis. I've talked about F0, F1, 2, 3, and 4. What I really want to highlight to you here, again, we are not doing biopsies routinely, but our hope is that our non-invasive markers help us get similar information. Slide E and F are what we want to try to prevent. Slide E is F3 fibrosis, also known as bridging fibrosis. And slide F is what a cirrhotic liver looks like on biopsies. The purple is the scar tissue, and the dark red are the nodules that form as the liver stiffens and hardens over time. So our goal in having this conversation is hopefully we can intervene and prevent the progression to E, and F, stage 3 and 4 fibrosis. Our goal again is to prevent cirrhosis and the multiple complications that come with this. I'll say that if any of you have a patient with cirrhosis, those patients should be referred to gastroenterology or hepatology because the acuity of their care is certainly increased, or they need liver cancer screening, and they also need screening for varices as well because of the risk of GI bleeding. Lastly, I want to focus on treatment. So multiple facets go into treating the patient with MASLD or with NAFLD. Our primary care and our endocrinology colleagues play a huge role in this. You are the gatekeepers for many of these patients. Nutrition and lifestyle, making sure that we manage those comorbid conditions, and involving your gastroenterologist or hepatologist when needed, and that FIB4 is greater than 1.3 becomes important. Diet and exercise, I know it sounds very simple, but these really are the mainstay and the focus of how we manage MASLD. Weight loss is important, healthy weight loss, I should say. Even modest amounts of weight loss can be impactful, particularly in those with mild disease. And we know that weight loss of 3 to 5% does improve steatosis, and that sustained weight loss decreases adipose tissue stress and improves insulin resistance over time. Diet needs to be focused on avoiding excess saturated fats, avoiding excess calories, and really avoiding particular carbohydrates as well. Fructose consumption ideally should be avoided. Just as we talk about the Mediterranean diet being protective for cardiovascular disease, it is also protective for MASLD. There's been a lot of conversation around coffee consumption. Independent of caffeine intake, coffee has been shown to be beneficial, but please don't go and drink tons of coffee, but just know that coffee is not bad for you when it comes to liver disease. And again, exercise. Independent of weight loss, we know that there's improvement in liver disease, and there's also significant cardiac benefit as well with exercise. And we should be routinely recommending this to our patients. I want to spend a few minutes talking about bariatric surgery. This really can impact outcome for our patients. For patients who have significant BMI, we should be referring them to bariatric surgery. And we know that many of our patients with MASLD and MASH would benefit from this as well. It improves not only the inflammation, it improves fibrosis, and sustained weight loss can cure diabetes and decrease morbidity and mortality. What I also want to share with you is that there's a big endoscopy literature and really big movements. We do this here at Ohio State now, where we are starting to explore really minimal invasive bariatric surgery techniques that we can even do endoscopically to try to alter the outcome and improve the lives of many of these patients. This was a study that looked at inflammation from fatty liver disease in patients before and a year after surgery. I want to focus your attention on the white bar. So before surgery, as you can see, there were no patients who had absence of inflammation, steatohepatitis, which is what the white bar stands for. A year after surgery, a significant amount of patients lost their inflammation related to fatty liver disease. So really, really makes a big difference. And when you look at fibrosis on the second graph, again, many patients after cirrhosis, we saw improvement in their fibrosis. They became F1 and F0 as opposed to pre-surgery, where many of them were not in that category. Again, this is showing the fibrosis stage before and after, and the improvement of bariatric surgery for these patients with MASH. I do want to highlight, though, the bariatric surgery is not recommended in patients with decompensated cirrhosis, and that is because of the significant mortality that these patients can experience after surgery. So if you're thinking about it for patients who unfortunately have developed cirrhosis, please consider sending those patients to a gastroenterologist or a hepatologist for further evaluation. But these potentially are those patients who we may consider for our endoscopic bariatric surgery techniques. Lastly, on medications, there are currently no FDA-approved drugs for MASLD at any stage. However, there are medications that have been approved for other indications and have shown benefits in patients with MASLD. The GLP-1 receptor agonists, as you all know better than me, are getting a lot of attention, and I want to highlight one of the studies here. So this was looking at semaglutide at 0.1, 0.2, and 0.4 doses subcutaneously over 72 weeks. And what they found was the resolution of NASH with no worsening cirrhosis, which was their primary endpoint, in a significant amount of patients. So placebo, so those patients who did not get anything, 17% of them achieved resolution of NASH. Patients who received 0.4 milligrams, as you can see, 59% of them achieved resolution of NASH, and this was statistically significant. So we do have some other tools that we can use. Obviously, this is for patients with obesity and diabetes, but please explore using this in your patients, because we know that even though not particularly targeted for patients with MASLD, it does improve outcomes overall. So in summary and treatment, there are currently no FDA-approved medications for the treatment of MASLD. However, drugs like our GLP-1 receptor agonist have been shown to have benefit in the appropriate clinical setting. And lastly, I want to mention vitamin E, because I'm sure many of you have seen this in the literature. It certainly can be considered in select individuals and has been shown to improve NASH in patients without diabetes. So future directions. Number of trials for MASLD has increased significantly over the last 10 years and continue to increase. We are working on further validation of biomarkers. Again, FIB4 is the take-home number, or the take-home test that we want our primary care physicians and providers to be using. And as AI develops in all aspects of medicine, we know that there will be adoption of AI-based technologies to allow us to better manage this disease and better determine the level of fibrosis and really where we need to intervene from a treatment perspective. We can all make a difference. Those of us at the back door in GI and hepatology, but certainly at the forefront, our patients, our communities, our leadership, and our policies, and certainly in education and awareness, in really altering the course of this epidemic of fatty liver disease, or steatotic liver disease, as it is now known. From a public health perspective, we know that changes can be made at the federal and state policies. That the rate of fibrosis progression and decompensation is dependent on so many, many different things. That also allows us to intervene on so many different levels. Cardiovascular disease remains a very common cause of mortality in patients with MASLD, even in the absence of advanced fibrosis. And we know that death from liver disease predominates when patients have developed advanced fibrosis. So we want to try to prevent that. An earlier identification of at-risk patients is essential to allow us to intervene at an early stage. Thank you very much for your time and attention.
Thank you so much, Dr. Conteh, for that fantastic presentation. And I will acknowledge we have had a little bit of challenge with the audio visual, and I appreciate everybody's patience. We have lots of questions, and I would like to get a chance to go through some of those. just a reminder, if you do have questions for Dr. Conteh, please put them in the Q&A function rather than in the chat if that's possible. And we will go through as many as we can. I think the first question we have is around what is the quote lay language you use to call MASLD, or how do you explain this type of liver disease when talking with patients, especially with low literacy, perhaps less than third grade, or when working with a translator?
Absolutely. Great question. And I think this is a challenge for all of us in medicine sometimes. So I want to acknowledge, as I mentioned at the beginning of the talk, that our academic societies want to change the nomenclature and actually have changed the nomenclature of this disease. But I will say, for us talking to patients, as much as that we want to avoid the stigma of fatty liver disease, I think that sometimes is the easiest way for patients to understand it. But I'll also say, don't just leave it at that, right? Because it's not only that. Highlighting those other comorbid conditions, the diabetes, the hyperlipidemia, the hypertension, highlighting those as well, the importance of exercise and weight loss. I think all those make a significant difference. So, okay to say fatty liver disease, but please make sure your patients understand that this is not simply an obesity issue, which is the reason for the change, that there's really significant metabolic dysfunction here that also needs to be addressed.
We have a few questions around diet. I think to summarize, is there a preference for a carnivore diet or a high protein diet with elimination of carbohydrates and sugars for the treatment of MASLD or for the improvement of symptoms? Or, is it really more of a balanced diet that you would see being supported?
Absolutely. That's a great question. So I'll tell you that my personal view is anytime we have a conversation around eliminating anything, I think it makes it very, very challenging for patients. It's almost that concept of when you say you can't have something, you want it even more, right? So I think the importance of focusing on a balanced diet is incredibly important. But again, because we know how significant diabetes impacts this disease, I think it's really, really important to drive home the importance of a low carbohydrate diet. Not a diet that eliminates carbohydrates completely, but a diet that lowers carbohydrate intake, fructose intake, for example. And to your question about protein, we are big believers in the liver world of high protein diet. Particularly when patients go on to develop cirrhosis of the liver, what we promote is low sodium, high protein diet for many reasons. Years ago, there was a focus in the liver world of patients should not eat high protein diet because it caused encephalopathy. We know that that is not true. So we really want a high protein diet, ideally a low carbohydrate diet, but certainly not a diet that eliminates carbohydrate completely. The other comment that I'll make on why we encourage a high protein diet, when significant fibrosis develops, the simplest way that I explain it to my patients is that the liver makes protein. And when you've developed cirrhosis, your liver is no longer able to make all the protein that it needs to make. But the body needs protein. DNA is the base for so many of our functions. So the body will go and take protein where it lives and where it belongs. And where protein lives and belongs is in our muscles. So many of our patients lose a lot of muscle mass over time. So focusing on that high protein diet becomes even more important then.
Thank you. And just another note on diet. What is the effect of the speed of weight reduction on the fatty content of the liver?
Yeah, great question. So I'll tell you that there's a lot of studies that are being done in this area. I think many of us recognize that with our GLP-1 medications that are now in use, we are seeing significant reduction in weight loss. There are studies underway that are being done as to, do we see impact in a month, in 2 months, in 3 months? because we are seeing patients lose significant percentages of weight on these medications. But what we do know, based on one of the studies that I showed you, looking at the bariatric surgery population, is that at 12 months, a year, we are seeing significant impact in the disappearance of inflammation and in altering that biology of many of these patients with significant weight loss. Again, we don't want to biopsy all these patients, right? And our hope is that as we improve our non-invasive testing, our NITs, that we are able to better assess what the liver actually would look like on biopsy and that degree of inflammation.
Thank you. We have a number of questions about medications, and just on the heels of what you spoke about with the GLP-1 medications, are you seeing any change in the ALT or AST with the use of GLP-1 medications? And is there any discussion around FDA approval for the use of these medications, specifically for patients with liver disease?
Yeah, so lots of conversation ongoing on that right now. But to answer the first part of the question, yes, we are seeing reduction in ALT and AST. So again, remember, unfortunately, not every patient with significant liver disease is going to have elevated ALT and AST levels. But when they do, it is helpful because we can monitor the improvement in those to help us determine how patients are doing going forward. But again, normal levels really should not reassure us that significant inflammation is not present, but helpful when it's high. So yes, we are seeing improvement in ALT and AST levels for patients who were previously elevated with use of the GLP-1 receptor agonist medications. And yes, there is talk ongoing as to whether these medications should be approved in patients with MASLD alone, because as we can see, again, for some of these studies with the semaglutide study I showed you, there is improvement in the fibrosis, there is improvement in the parameters with these medications. One of the challenges that we are facing right now is just insurance approval. Hopefully with FDA approval, that will get better. But even many of our patients after transplant, unfortunately, many times go on to develop fatty liver disease again. And if they don't have diabetes, even in the presence of obesity alone, we're having a very, very hard time getting some of these medications approved for them, even though we know that it will make a difference, unfortunately.
And just to wrap up our questions, I know there are still questions we will not get to today. We will try and have Dr. Conteh give us some answers to those. We'll make them available to everybody who's here. But finally, we have a number of questions around the dosing of vitamin E and the effectiveness of vitamin E for those with and without type 2 diabetes, with MASH and MASLD.
Great question. So vitamin E is one of those things that's been around for decades. I remember using it when I was a medical student. It went out of favor, and then it's coming back in favor a little bit. So really approved for patients without diabetes, and just a standard dose is fine once a day. What I will say though around vitamin E is we have better things. We have better things in place that we can use. We have GLP-1 agonists that we can use. We have better statins that we can use for these patients. There's so many better things that we can use that have been shown to show benefit that we should turn to those things. And again, remember that bidirectional relationship between MASLD and diabetes. Many of these patients do have diabetes, and vitamin E is approved for patients without diabetes.
Wonderful. Thank you. We really appreciate your time today, Dr. Conteh, and on behalf of everybody who joined us, I want to thank you for a wonderful presentation. I'm sorry we didn't get to all of these fantastic questions, including ones on behavioral health disorders and liver disease, among others, but we will try to address those. And with that, I think I will pass it along to Sherry to wrap things up for us.
Thank you both to Dr. Conteh. That was a fantastic presentation, and Dr. Zack for helping us moderate this wonderful talk. If you go to the next slide, just a few last items. Just again, if you join late and you want to claim CME credit, you do need to register. So if you didn't register, just go to the QR code or the URL and do that. On the next slide is just letting you know that we do want to hear from you. We're going to send a survey for you to complete at the end. It will also be sent by email. We want to know what was good that you liked that we should continue and what you might want to improve for next time. And the next slide, we'll look at announcing our next webinar already for Wednesday, May 22nd, 12 to 1 on social determinants of health, implementing screening and taking action by Dr. Rachel Gold from Kaiser. So we're excited about that. And next slide, just ending. Thank you all for coming and listening with us today. If you want to hear more about cardio, you can go to our website at cardio.org. And you can subscribe to our monthly cardio update newsletter there as well if you'd like to get those. And you can follow us on social media if you are a social media user. So thank you all for coming. And thank you again to our speaker moderator for joining with us today. Have a great rest of your day.